very much indeed, Gert and Matthias, and thank you all for choosing to spend an evening with me. Well done. I hope you're enjoying your alcohol-free beer. As Gert said, my name's Luke, and I hang out in London in the United Kingdom, and the problems that I have may or may not resonate with you. I suspect some of my problems will, and some of my problems are different to yours. But let's try and, first of all, shape the problems we have so that together we can try and form some solutions. Before we go any further, I'm grateful to bioMérieux for enabling us to be here this evening, and I have some other disclosures which I hope won't inform too much about what I'm going to say. Every single person in the room will have used diagnostics before. You will either perform the diagnostics yourself, you will order the diagnostics, you will request one of your healthcare professional colleagues to request a diagnostic. All of you will also receive the results of diagnostics and try and put those in the context of the patient you are trying to serve to make their life better or longer or both. The problem I have, and this is a problem that I think will resonate with you, is that not all of those diagnostics are performed correctly, either technically or for the right patient at the right time. Not all of those results are then intervened into that patient's care for impact. That's the first problem. The second problem, which we probably all share, is that when I want a new bit of kit, when I want a new diagnostic test, my pockets are not infinite. My hospital's pockets are not infinite. So when I speak to the hospital administrator, I have to create an argument, a case, towards developing a new service, implementing a new diagnostic. Does that resonate with you? Give me some nods or shakes. If you give me too many shakes, I'll get off the stage and walk away. But yeah, right? The problem I have when I'm speaking to hospital administrators is that they focus in on cost. And cost is a very different word to value. Cost ends in a dollar or a yen or euro or a pound. But value has lots of different units of measurement, doesn't it? And depending upon through which lens we look at that value, you can either build a better argument, a better case to the hospital administrators, or you can fall flat on your face and not get the bit of kit which you believe is going to make your patient's care better. So let's try and think about a systematic way in which we can make all of our arguments better when we're looking up towards those people whose pockets are also not infinite, but perhaps deeper than our poor clinician pockets. I'm going to start, as always, at the beginning, thinking about how you and I, as clinicians, use diagnostics. And I think there are three main areas in which we want a diagnostic test to help a patient with an infection. First of all, when we're thinking about should we have a go, no-go on an anti-infective agent, then we might want a slightly different diagnostic test when we've got a bit more access to invasive patient samples to help us finesse, optimize that on-treatment stage of a prescription. And then we really want to know when to stop, because gone are the days of a set number, a set duration of antimicrobials. What we want to do is personalize that cessation. With me so far? If you zoom into that, Tim Rawson and I have tried to go into the detail to try and understand how each of us has a decision-making process around antimicrobials. And these great blobs may or may not resonate with you, where you work, about how you prescribe. But if you go into the detail, the core components of how a prescription for an anti-infective has arisen, then perhaps those core components do resonate with you, depending on what access to diagnostics you have, acknowledging there are citizens joining us from all around the world today who may or may not have access to all the different elements in that core component. But you can kind of batch those things, those diagnostics, together with other non-diagnostic tools, guidelines, clinical vignettes. But you can try and put all of those things together across that patient journey. And then if you do that, you conceptualize how you arise at a prescription for an antibiotic, what tests feed into that. You can then start to enumerate the outcome metrics for that one patient. And those outcome metrics might be different antibiotics, less antibiotics, more antibiotics. They might be death. Death is hard. Might be morbidity, might be length of stay. You can start to then put names to the things that we can measure relevant to one patient. Now, this is not new news. This should not be new news to anyone in the room. This is what we're doing all the time with our current business cases. But actually, there's more to be gleaned from a test than just that. Put a pin in that. Let's go right to the top of the decision-making process. Each of you will have more effective, differently effective, hopefully not less effective departments of health or ministers for health. Back in the mid-2010s, they were commissioned by the WHO Global Action Plan for each of your ministers of health to write their own national action plan. And there's what, 206 countries in the world? So you'd think that there were now going to be 206 national action plans for antimicrobial resistance. And you would hope, I'm sure, as healthcare professionals, that each of those national action plans would have something to say about diagnostics. That's what you'd hope, right? If you're going to have a national action plan to fight AMR. When Asmita Chirani, colleagues from around the globe, and I looked at this, however, a few years ago, we found that there was variable writing of these national action plans. And actually, when you zoom in, of the 206 countries in the world, only around half have actually written their national action plans for how we will address the AMR pandemic. Sad face point number one. Sad face point number two is that in those half that exist, only a quarter of those said anything at all about diagnostics being useful to address AMR. Isn't that a poor state of affairs from our ministers for health? And actually, even within that quarter of a half, so an eighth of the world, only an eighth of the world think that diagnostics are important for AMR. In that eighth of the world, actually, there's a lot of variation, a lot of hand-waviness, a lot of smoke and mirrors about how actually diagnostics will help us address AMR because of lack of appropriateness of different platforms to help with your own national issues. How those results are then being integrated back into patient care rather than those results just poofing onto a computer screen or a printout. Fast forward to now, Virginia, colleagues from around the world and me have updated this and zoomed in on diagnostics. This is just coming out in Clinical Infectious Diseases. I'm not going to big up my own paper, but I'm bigging up my own paper. So read this upcoming edition of CID, and what you'll see is that plus point, more countries have now written their national action plans. Plus point number two, within those national action plans, more countries are acknowledging diagnostics will help us fight the AMR pandemic. Plus point number three, countries are starting to get specific. But actually look at the countries that are most specific about trying to drive forward a diagnostic agenda to fight AMR and actually write down how we should be using them. The countries we should be looking to are not the United Kingdom. The countries we should be looking to are in the Africa WHO region, are in the low and middle income country areas where they're writing down, don't just do a test and send the result off into the nether. If you're going to do a test, make sure the result impacts patient care. I think that's where we should all be aiming, and I certainly am learning from that. But when we're trying to do that, when we're trying to go from the zoomed in aspect of how we are all comfortable with using a diagnostic test for one patient, through to the other end where our governments think we should be using diagnostic tests to help fight AMR, in that spectrum there are potential problems and there are potential opportunities. Now, we know the knowing of the specifics because all of us here heal the sick. But we're not, well, some of you may be policymakers. If you are, listen closely. But everybody who's not a policy maker in the room, we know the knowing about diagnostics because we're the infection experts. But it's up to us to inform upwards about pitfalls and opportunities. So what are they? So when we're zooming in and when we're trying to speak upwards about a new bit of kit, about valuing a new diagnostic test, those of you in the room who don't just heal the sick, but derive science from healing the sick, you who are academics, clinical academics, what we need to think about when we're trying to start to develop evidence base behind diagnostics is to constructively align the bit of kit we are doing a study on with the outcome metric we are trying to promulgate. So, for example, if you're trying to roll out a rapid diagnostic test to help you start an antibiotic, a good thing to perhaps measure would be appropriateness of antimicrobials. Gert didn't mention, but I have a very laborious job, as I'm sure many of you do, which is to be an editor in a journal. And I get too many manuscripts coming across my editorial desk where the great and the glorious in our community have rolled out, for example, a rapid diagnostic test and looked at the impact of that on mortality. Do you know how hard it is to impact mortality with anything we do, let alone a rapid diagnostic test? So actually what we need to do, part one, pitfall number one, is for all of us who have any interest in academic studies around diagnostics to make sure we constructively align the test we're rolling out with the impact we're trying to measure. Point number one, to generate evidence to push upwards to describe the value of a test. Problem number two is that, as I alluded to earlier, you're from around the world and you're going to have different access to different tests, and they're not universal. But actually, if we're going to think about avoiding pitfalls in the country in which you work, you kind of need to take an inventory of what types of tests, what types of bugs are relevant to you. And if we move forward into the opportunities to kind of circumvent that, Anusha from Thailand, colleagues from around the world, including Virginia and I, tried to say, okay, there are lots of problems with diagnostic tests, but what are the opportunities? And these are our 5 take-homes for kind of what you can do on Monday morning or, well, Wednesday morning after ESCMID have done. So if you're going to try and optimize a diagnostic pathway in your institute, really work out what tests you've got there, work out who those results are going back to. You may know what to do with a printout of a syndromic multiplex PCR. I would argue a jobbing junior doctor or cardiologist or care of the elderly consultant may not. So you need to be working out where those results are going back to. You need to be developing key performance indicators relevant to your patient group, and you need to be documenting that and externalizing that through peer review. And then you need to be thinking about how you're going to do that within the resources you've got. Right. So we know how to impact one patient's journey with a test. We know the different elements of that patient's journey where different tests could impact. We know what our governments say we should be doing to utilize diagnostics to address AMR. There's still a big gap there. We've identified some of the pitfalls there, some of the opportunities on Wednesday morning you can go home and do something about. But when you wrap all that together, how still are we going to prove to the people who pay the bills in our hospitals, those hospital administrators, that getting a new bit of kit, a new diagnostic, will help not just that one patient and not just appease our ministers for health, but actually derive greater value than the financial cost of that test? So as Gert alluded to, the OHE, the Office of Health Economics, did a snowball recruitment deep dive into what infection experts from around the world think can be done about that. And they started to build this into a framework, and this is out for peer review at the moment. So I don't have a reference to give you, but there is a white paper. And they said, well, first of all, there are general value and diagnostic specific value elements to a diagnostic test. And you'll say to yourself, what the dickens does that mean? If you come to me with a respiratory syndrome and a high fever of 39 degrees, and I say to you, you've got rhinovirus, that's of zero value. Or is it? Because that means that you do not have COVID, you do not have influenza. Please have some paracetamol or acetaminophen. Please go home and feel free to return to work. Now that has value, doesn't it? Even the word rhinovirus has value. You've put a name to something, you've calmed something down, you have stopped other interventions from happening, costly interventions. You've returned that taxpayer to work to pay tax to support your health system. But specific to that, in our world, there are things that we enumerate for other reasons anyway, that we perhaps need to constructively align in studies we're building so that we can start to actually enumerate the impact of that diagnostic test across other things. And the first and foremost of those is some of the metrics we already collect data on for antimicrobial stewardship reasons. And I anticipate that many, if not all of you, are, as part of your job roles, engaged with antimicrobial stewardship endeavors. You're wanting to narrow down the spectrum of antimicrobials. So if you're doing a study on a diagnostic test, what is the value of that decreased spectrum? Now, that may be a value in pounds, yen, dollars, euros, but it may actually be a value ecologically over time with your surveillance data looking at decreased resistance. I'm less concerned with the units rather than the framework of how we need to start to collect data as an infectious diseases community. So point number one of the STRIDE framework is to try and put data around the impact of a diagnostic on the spectrum of antimicrobial being used. The second is on transmission. If you can identify with the diagnostic test the patient in front of you has a transmissible disease, you're probably going to segregate that patient, you're probably going to use some PPE. And what is the numerical secondary attack rate improvement there? How many cases are you preventing from happening by implementing that diagnostic test? Third, there's the research element. Lots of us who are jobbing clinicians, and I am a jobbing clinician, we want to have a yes-no answer very quickly. But actually, there are lots of assays out there, sequencing, that don't ask a yes-no question, but ask an open research question. And there is a value there. Let's think about, I don't know, pandemic preparedness, right? Then there's the insurance value. So if you have one diagnostic test for antimicrobial susceptibility testing or antimicrobial resistance gene detection, and that assay goes down, that company goes bust, that supply chain gets intervened by a war, then you've got a problem. What is your insurance value then of having two different pluripotent platforms that you may use more of one to do CRE testing, more of another to do respiratory virus testing, but if there is a catastrophe at the global scale, can you flex those platforms? What value has your diagnostic test in enabling diversification? I'm not going to get into a diversification versus cycling argument with you all, because we all want to go out and enjoy a nice German sausage and beer later. But there is a numerical advantage to that. Enablement is a funny one, isn't it? If you prescribe someone an antimicrobial, does that enable something else to happen? Does it? What about if you have a patient who you're just about to give Folfox chemotherapy to or slice her abdomen open to take out a bowel cancer? Does the ability to have the right antibiotic matter to that person and enable that oncologist to prescribe, enable that surgeon to do the surgery? Yeah, it probably does. But inherent in that is getting the right antibiotic, and inherent in the word right is a diagnostic test. So what value has a diagnostic test to advancing other bits of medicine, surgery, cancer? And then, of course, the one which we're already pretty good at is the last S, which is surveillance. So how do the results of diagnostic tests feed forwards into us knowing what the situation is where we're working? And you might all think we do that quite well. I think we do that quite variably across the globe, actually, if I'm being fair. And I think there is a lot of data being generated from different diagnostic platforms that's just sitting there not doing anything. So I think across all of these elements, there is something to be learned, something to be ascribed value when we are thinking about the utility of a diagnostic test being rolled out in your organization. I'm going to demit there, Matthias and Gert, and hand back to you two as chairs. Just wanting to reiterate the value of a test we must think of as being greater than just helping one individual patient at a time. Thank you.